Hear me okay?
Yes, we can.
Okay, good. All right, so I'll start here. So, as I was saying today, we'll start on this talk called Dysphagia Awareness and Readiness for People with Parkinson's Disease. And again, I'm Karen Sheffler. I have a master's degree in speech language pathology, that's the SLP, and I'm a board certified specialist in swallowing and swallowing disorders. There's a few hundred of us around the country that have that special board certification. I also have the swallowstudy.com is the website. And if you're savvy on social media, I can be found at Swallow Study SLP across all your good Facebook and Twitter, which is now X, and Instagram and LinkedIn. So look for you out there if you're on social media. So we're going to dive in here and our Parkinson's disease awareness. You can see these lovely red tulips. Parkinson's Awareness Month has these red tulips and the PD written there with the leaves. So I love that icon of the Parkinson's Awareness Month. Um, and there's research out there that's starting to say, are we in a Parkinson's pandemic? Like the last thing we want to hear is pandemic, right? Um, but it really is something that requires a big heightening of awareness because there are a lot of people around the United States and around the world with the diagnosis of Parkinson's disease. In the US, people 45 years or older, there's now well over 1 million people that are projected by 2030. Worldwide, 9 million by 2030 and 17.5 million by 2040. And as we know, with Parkinson's, a common source of decline could be from pneumonia or falls. And pneumonia and choking risks may be increased because people have difficulty swallowing. So the concept of difficulty swallowing is called dysphagia. And with Parkinson's, you also need to have dysphagia awareness because often you'll be getting evaluated by your doctor, and the swallowing problems tend to be more subtle. When you have difficulty swallowing, again, it's called dysphagia, and up to 95% of people with Parkinson's disease may have some difficulty with swallowing. The difficulty might be to solid foods, liquids, pills, or even swallowing the saliva. And that's a lot of information I just threw on those two slides. So we're going to break that down through the course of our talk here. First, we're going to talk about a swallowing overview. And so normal swallow anatomy, if you remember way back to your anatomy classes, and this is the side of the head. So we're looking at the head from the side here. Swallowing is so complex, and there's a lot of muscles involved. So as it says here, swallowing is complex. It has sensory, that's kind of how we feel things, and motor involvement. And it's a neurological and physiological process that requires really precisely coordinated, really synchronicity of movements of over 30 pairs of muscles. And so some of the anatomy here that we're just going to point out, you can see nose here. As the nose goes back and hits the throat is also called pharynx. So this is the nasopharynx up top. This is the mouth or oral cavity, and the oral pharynx, where your mouth, the back part of your mouth, meets up with the throat, or called the pharynx. You can see how big the tongue is too. The visible part of the tongue that we see is really only this front part, but the back of the tongue, it creates this tongue base here, and that's actually the front wall of your throat. And then the back wall of your throat, or pharynx, and then down in your lower pharynx, some people call that a hypopharynx, or down the lower part of the pharynx. And that is right close to our open airway, our voice box here. So the vocal cords and this big kind of triangle shaped larynx area here. And that's your hyoid bone there. The cool thing about the hyoid bone is, if you guys ever played Trivial Pursuit, it was a question on Trivial Pursuit of what bone in the body is suspended above and below from muscles. And that answer was hyoid bone. So, I'm in my 50s. I remember Trivial Pursuit, but a lot of the young ones don't remember that anymore. And so here you see your vocal cords and into the trachea, and then this is your food tube, or your esophagus, down through here. And so normal swallowing has 4 phases. You're first preparing your food in your mouth, you're taking a bite, starting to chew, and then the oral phase is you put it all into a ball, and then you send it through your throat, or the pharyngeal phase. and then it sends down into your esophagus, so that food tube. The crazy way that we were made, which, it gives me a job, but it also makes swallowing quite challenging, is that this green line here is the food. So, of course, food goes across the back of the tongue, down through the throat, crossing over that open airway there. You want that airway to completely close up, and then it goes down to the esophagus. So we are breathing and swallowing down this same passageway. When we swallow, we've got to close that airway up. We can't be talking or laughing or doing anything like that. So that crazy anatomy that we were built with can really cause a lot of safety and efficiency problems. So a safe and efficient swallow is that you protect your airway, you prevent things from getting down the wrong way. As we say, down the wrong pipe. That's when things go into the larynx or down into the trachea. That's down the wrong pipe. So we need a safe swallow to prevent that. And then we need an efficient swallow. We need to push with the tongue, squeeze with the throat, get the food and the liquid and the pills and saliva all down without leaving residue behind. So this is another sort of cartoon depiction of the first one here. A is oral phase. You see the food just sitting on the tongue there. This green ball here, we can call that a bolus. So if you ever have a swallowing evaluation, you go into your speech language pathologist and you'll be like talking the lingo here. You're like, well, my bolus is sitting in my throat. You can be kind of fancy and talk the lingo because when the food or liquid is in the mouth and we form a ball with it, we call that a bolus. And so here you can see it's formed the bolus, it's pushing to the back of the tongue. And then here in the C picture is the start of the pharyngeal or the throat phase. And it's the start of when that hyoid lifts forward, the whole voice box lifts up with it and closes everything off. So the whole larynx lifts up and out of the way, the epiglottis flips down over, and this should be totally sealed up so that during the pharyngeal phase, when that food is going through the throat, everything's sealed up and nothing's poking down the wrong way. Into the esophageal phase, this upper esophageal sphincter has to open, and then the food has to clear down through that food tube. And so what is dysphagia? What's aspiration? Why are we worried about pneumonia? So why do we have dysphagia when we have Parkinson's? One of the most common things that we see right away when we're looking at people in this X-ray swallow study is when the food's in the mouth, sometimes there's a rocking of the food back and forth, which is why I have this kind of arrow back and forth here. The beginning of the mouth phase to pushing it back, sometimes people are rocking back and forth with the food. It's kind of similar to when you're getting up from a chair. You might have kind of a 1, 2, 3, and you get up. So shifting into a different movement with your body. That's also seen with the tongue. So sometimes rock, 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 and then the swallow happens. So it's just something to be aware of. Of course, with Parkinson's, there might be reduced movement or rigidity. There might be slow movement or bradykinesia. And then it might end up having some weakness with the tongue, in the throat, some discoordination of all that timing, as well as like a delayed swallow. So when you send the food back, sometimes that process can be slow. And then sometimes when the food hits the throat, the swallow doesn't trigger right away. And this is a matter of milliseconds we're talking here. And then also a lot of research has found lately that if something pokes in the wrong way, there's a blunted or a decreased urge to cough. So, if I took a drink of water and I got a little bit down the wrong way, I would just respond with a big cough. Sometimes in people with Parkinson's, is just a decreased urge to cough, a decreased sensation of liquid getting down the wrong way. The other thing that new research has found is that when people with Parkinson's are trying to do too many things at once, we're all so used to multitasking, but the swallowing can be a little harder if you're trying at the same time to do a motor task or a cognitive task or work on your computer and eat at the same time. That can be harder. So it's just something to be aware of. And so aspiration is one outcome of dysphagia. Dysphagia, again, the definition here again, a difficulty with the safety and efficiency, sort of difficulty safely and efficiently moving food, liquid pills, and saliva from the mouth through the throat and into the esophagus to the stomach. Aspiration is one outcome of dysphagia, and that can be caused when the airway is not protected up. So you see in this picture here, this is the side view of an X-ray study. We give barium, and so this big, way too big of a sip that somebody took, you see the barium in the mouth coming down through the throat, and then it's starting to poke down the wrong way. It's poking into the larynx here because it's not sealed up, and then it's getting down towards the vocal cords and then hanging below the vocal cords along the front wall of the trachea and the back wall of the trachea. So this is a big aspiration. This is not that common. Typically it's like just little trace aspirations that we see. But this aspiration just kind of nicely outlines the structures. You see the larynx and then the vocal cords and the back wall and the front wall of the trachea. And so dysphagia can cause either aspiration, a safety problem, or it can cause food getting stuck in the throat or a residue problem. And so this one study really kind of helped us define how many people with Parkinson's are developing some kind of trouble swallowing, even if it's just mild troubles. And this study showed that only 5% of people have a completely normal swallow through their Parkinson's disease. Um, People who have more trouble with like voice issues and more close to the body issues may have more trouble versus somebody who's just having some gait trouble or some, down the leg problems. So it is something to be very aware of because 95% of people with Parkinson's will have some kind of dysphagia, sometimes at the early stages, but other times at the more later stages, especially if there's some cognitive changes down the road happening. And problem with old studies is that a lot of times in the old studies, they just ask somebody, do you have trouble swallowing? And they said, nope. Okay, well, our dysphagia rates in this population is only 11%. So, so it's, when you only ask somebody, do you feel trouble swallowing? You might not get a very high amount of people saying, yes, I have trouble swallowing. And that's because often people can't feel the food stuck in their throat. They can't feel stuff getting down the wrong way. Parkinson's, we think of it as such a motor problem, but it also can cause this sensory loss in this area of food getting stuck and stuff going down the wrong way, which is why it's so important to see the swallow inside. We don't have x-ray vision on the outside, so we have to see the swallow on the inside with an x-ray or endoscopy. So, it's not always an aspiration issue. In this study, they found that residue was the most common finding. So out of 119 people, 111 had some amount of residue when they looked at the swallow. And bread was the most common buildup food. That 50% of those people, it was bread that was really giving them the buildup, and 19% of those with actually a really severe choking risk with bread of too much buildup in the throat. And I wrote a recent article on my swallowstudy.com about how bread, people think it feels soft, but often bread is pretty hard. And the problem is when we start chewing it, it ends up getting kind of slimy and gummy, and it can really stick in the throat. So it's just something to be aware of and to try and make modifications as needed. We'll talk more about bread later. And so with pneumonia, pneumonia may be so common in Parkinson's because people do commonly have trouble swallowing. So just to define pneumonia, people use a chest x-ray to see, are there new markings on your chest x-ray? Sometimes it doesn't show up so well on a chest x-ray, and your doctor may have you do a chest CT or a CAT scan. And you'll maybe, if you're in the hospital with a pneumonia, you may find that you have a white blood cell count increase, may have a fever, and then the symptoms are good to know about because sometimes they can be more subtle. It's not everybody gets the shortness of breath or fever. Sometimes it's some chest pains and even abdominal pains, or just like a fatigue or a loss of appetite or new confusion or things like that. So caregivers also can be aware of the more subtle characteristics of pneumonia and double check with their doctor doctor if those things are happening. And so coughing up phlegm too, it's always good if you're coughing and expectorating nicely, just take a look at it and report the color and the amount and all those things to your doctor. But with dysphagia to aspiration, it doesn't automatically equal pneumonia. It's just not so simple. So as I say here, aspiration does not automatically equal pneumonia. And that's good news for us because we can do things to help prevent pneumonia. And so the triggers for aspiration pneumonia, it needs you to aspirate, of course. So whether you're aspirating a little bit of liquid down the wrong way or particles of food, just that alone doesn't mean you're going to get pneumonia. Um, there needs to be other things happening. So the sort of the recipe of pneumonia or the other triggers for aspiration pneumonia are these: that if you already have a weakened immune response and can't fight off infection, that might be an issue. If you have poor respiratory response, if you have a history of smoking or you're mostly bedridden, you're not going to have good pulmonary clearance or lung clearance to kick the stuff out of there. So you really do want to keep moving, as you see the guy here exercising. So keep moving, keep coughing, keep trying to raise things up. Physical therapy can do a lot actually to help with the cough, as can speech therapy. You really want to encourage people to cough, to expectorate, to have good clearance of stuff out, and there's tricks to help with that. Um, and so poor oral hygiene is a huge indicator. If somebody has kind of the nasty bacteria building up in their mouth, that can get down into the lungs if they're not keeping their mouth really clean. And when you're dependent on somebody else to help clean your mouth, that can make things worse. You guys were talking about being in the hospital, and so when you're in the hospital, you tend to, like, the last thing that people think about is like, get your toothbrush out and brush your teeth and keep your teeth clean, because you kind of get out of your general routine. It's always great to bring like an electric toothbrush into the hospital, or just having an electric toothbrush constantly anyway, to keep the mouth really clean. That can actually help prevent aspiration pneumonia. So in terms of getting a swallowing evaluated, here's some potential signs of swallowing problems. So if you have these signs, it's things to think about, to talk with your doctor about, because then your doctor can help you get your swallowing evaluated. And that is by a speech pathologist. So they can refer you to speech pathology. So if you're having obvious signs, that might be actually feeling food, pills, or liquid getting stuck. You also, as you're trying to swallow food, liquid, and pills, maybe you're coughing, like, especially taking a pill plus taking a liquid can be a really challenging thing. It's like two different items to try and swallow at once. So that might make you cough a lot on your liquids when you're trying to push the pill down. And we can talk more about strategies of that in the future. So constant throat clearing also, or feeling like a tickle or a burning sensation. I just worked with somebody today at the hospital where I gave him some cranberry juice and he said, "That feels spicy." And I was like, "Do you mean that you feel it burning?" And he said, "Yeah, yeah." And so he was feeling a burning sensation in his throat. So like a tickle or a burn as you're drinking might mean that something just got down the wrong way. And so it's just good symptoms to be aware of. So feeling an airway blockage, feeling difficulty breathing when you're eating, that might indicate an actual choking risk. And you really want to just cough. Coughing is a good thing. So feeling liquid coming back up is another thing. So we want to know, like, what are the symptoms with stuff going down? But sometimes people have esophageal problems and stuff gets stuck or comes back up. So those are really important things to share with your doctor. Other times it's up more in the mouth, where you maybe have drooling or spilling of things out of the mouth, or getting things stuck in your cheeks, or just even you take a bite of food and maybe it's a tough piece of meat and you're just having to chew for a really long time, and your chewing feels a little less strong and maybe makes you more fatigued. Um, and so the less obvious signs here, in addition to being more fatigued with a meal, maybe you're having an unexplained weight loss too. You're not eating as much, or it's taking you longer to eat. That might give you an unexplained weight loss. And then all these other things that the doctor looks for is, are you having repeated chest infections or pneumonia from eating during a meal, or maybe the pneumonia is from refluxing and getting things down the wrong way after a meal. Um, there's also, shortness of breath. So as you're eating a meal, you may start feeling fatigued or just kind of, having a big work of breathing, or getting short of breath while you're eating. There may be increased congestion during or after meals. Maybe you're always spiking kind of low grade temps, like a 99 or 100 temp, or just even in general change in the amount or the rate of eating. A meal that used to take you 15 minutes to eat maybe now takes you 45 minutes to eat. Those are huge, important information to share with your doctor and your swallowing specialists. There's screening tools out there that are better than just this unified Parkinson's disease rating scale that your doctors use to rate your level of Parkinson's severity. It really only has one question on swallowing. So as your friendly doctor is there and marking things down, that questionnaire alone might not dive into swallowing enough. So you need to share the things with the doctor, advocate for yourself. You can even pull up this Eat 10. So this is a just 10 question easy questionnaire. Nestle, and I have nothing to financially disclose about Nestle here, but Nestle has a nice PDF on this website link, and the PDF that I shared with all of you, all those links are active. So as you look at the PDF online, you can just click and follow my links and suggestions. But this PDF is nice because you just fill in the questions and it gives you your score, and you can just share that directly with your doctor. It's super handy. Um, across the pond, as they say, over in Munich and in Europe, they have an actual screening test for Parkinson's disease, and I gave that German link here. It is kind of a very rudimentary website that it'll take you to. But the nice thing is when you click on questionnaire, there's a nice drop down of questions. And there's many questions there that really help you think about, what is it that I'm having trouble with swallowing? And then when you come in to see a speech pathologist, they'll do a clinical swallowing evaluation, or also called a bedside swallowing evaluation. That's all the interviewing and looking at your mouth and your voice and your cough and giving you foods and liquids. And it's all like observation, just here in the office. But we can't see down inside your throat. So we need to have other examinations, either this X-ray examination called video fluoroscopic swallow study. It's also called modified barium swallow study. It's good to know both of those words because some hospitals will call them one or the other. It's the same test. And it's a motion x-ray, and it looks at the whole swallow from the mouth all the way down the esophagus. And we give you lovely barium food and liquid and even a barium pill. So we can really try and make it as functional as possible, but we get to see everything going down. And we'll look at more of those today. There's also the fiber optic or flexible endoscopic evaluation of swallowing, or FEES, and that's just a tiny thin scope, kind of like little bigger than this wire here, a thin scope in your nose. They can numb your nose up just a little bit, and it's really not painful. I've had it done multiple times. So little scope into your nose, it hangs down the back of your throat, and they just watch your swallow from that picture, and we'll see one of those as well. So why do we need these instrumental exams, the X-ray or the scope? And we really need to see inside to figure out what structural issues are happening and what muscle movement problems are happening or timing problems are happening, because we can figure out what's causing this dysphagia or this difficulty swallowing, and we can analyze the different things. Is it food, liquid? Is it pills? What's going down the wrong way? What's getting stuck? And why is it happening? And what can we do about it? What therapy can we do for it? Or how can we tweak and modify how you eat and what you eat to help you tolerate things better? And so this picture here is a picture of liquids getting down the wrong way. And so you can see here, this is the same image that we were just looking at, is as the person swallows there, liquid was getting down the wrong way. And there was no reaction, there was no cough with that. I'm also going to show you residue here. This is when some people don't always feel the residue there. Let me just slow that down there. And so as the food comes down into the throat. You push with the tongue, squeezing with throat muscles, and it left food behind there. So the food is behind the tongue in this pocket and down near the open airway in this pocket. And so this person was told, swallow again, give it a hard push, push with your tongue. Oops, I'm sorry, that just clicked off of it. So seeing that again there, swallows, leftover, push hard. And here comes the next swallow. Good. That hard swallow pushed the rest of it down. So that's kind of the type of thing where we can see it on x-ray. We can see what to do about it right away. And sometimes you'll find a strategy that just works perfectly, but you need to see that on x-ray to know. If I had x-ray vision, that'd be great, but I haven't developed that yet. So to dive into swallowing treatment, and also just to pause, if Teresa, if anybody has any burning questions that have already been put in the chat, you can just pop in and let me know, because I'm going to go into some treatment part of things now. Just pause there.
Well, yeah, I don't actually
Yeah.
see any. I think they're just
Okay.
absorbing everything. So
I know, which is why I wanted to just like, let's just take a break
I
because
appreciate it.
we'll
Yeah.
answer questions, and don't forget you have the handout, and you are also going to be able to see this recording that we're doing. So all right, so for swallowing treatment, it's also called dysphagia management, just to have all the lingo here. Um, Dysphagia therapy or dysphagia management, the foundation I'm going to say first here, I made this little graphic, and the most important thing I think is this person-centered care. So whatever treatment you're doing and whatever conversations you have with your medical team about your overall treatments, it always has to be on a foundation of you understanding the rationale. So I could go in and just recommend somebody, oh, you need pureed foods. It's like, well, give me the rationale for that. Like, so, any treatment that somebody is trying to throw out there, it needs to be in a person-centered care approach so that the person themselves needs to have good understanding and good rationale to help them make an informed decision. So us caregivers and healthcare providers, we need to make sure that we're targeting right to the individual's goals and wishes. Because if I tell somebody you need pureed food and they're like, well, that's really not in my preference, it's not in my goals of care, I'm going to accept a little bit of risk and I'm going to do these things to try and minimize my risk, but I don't want, you know, all this restriction and all, so there, within the field of swallowing, there's lots of things we could do that might interfere with quality of life. And so when you're having discussions with your team, you really want to make sure that you're understanding all the rationale behind the recommendations so that you can, put together the pluses and minuses, the risks and the benefits of any decision, and then come up with a plan that works for you, and that, that everybody's on board with, because you are the center of your team. So a medical team, the person is in the center, and that's really crucial to just always remember that, because then you can advocate for yourself. So of course, dysphagia therapy, the planning starts with good underlining testing. We have to know what's going on inside with the swallowing to figure out how to target treatment. How can we guide treatment based on the evaluation that we did? So sometimes it's in these three pillars here. So sometimes the first pillar, we're going to have some of our therapy might be like, okay, well, if you just take smaller sips, that's effective. If you cough and reswallow, that's an effective strategy. Or if we just tweak your diet a little bit, like add extra sauce, make the food a little bit more slippery, or make the food softer, those are diet modifications that we're going to talk about in a bit. Um, so we provide these kind of options in this sort of pillar of dysphagia therapy. And then another big pillar of dysphagia therapy is all the education and training and the counseling that we do. And some of it I've already done with you, like, how do we make sure our mouth is really clean, and how do we prevent pneumonia? How do we prevent choking? There's a lot of good counseling that we do with people and with their caregivers too. And then the other pillar is rehabilitation. So we can look at what's going on with the swallow and figure out, okay, well, your tongue is a little bit weak. So if we strengthen that tongue and get a better push on the swallow, then maybe the swallow will, just drive down through your throat better. So there's exercise programs that can be targeted to the person. And so the first pillar, as we said, looking back there, the first pillar includes like diet modifications and these strategies. So the first thing here that I'm going to talk about is food and liquid modifications. And so with this, the International Dysphagia Diet Standardization Initiative, it's the website that Teresa found us on. She was asking, gee, this itsy looks like a great thing to train people that have trouble swallowing, because this gives us a standardized framework. What is soft, what is thick, what is, what are these diets, and we want a standardized framework to work within when we have difficulty swallowing. And this actually is now a global consensus. So when the United States can't agree on anything, we actually are seeing the world agree on this. So there's lots of different ways to modify foods, but this was an effort of the whole world to make a consensus on what do we call these foods, and what descriptions do we give them, and what definitions do we give them. They made them with words that are easily translatable. It's already been translated into well over 20 languages. And our international group of this, we already have well over 50 different countries around the world that are signing on to this, and really have a drive to standardize our foods. Your speech pathologist, based on your evaluation, would be recommending different diets. So with the liquids, there's regular thin liquid that we all drink, just water and tea and that kind of thing. And then the slightly thick liquid might be like a Boost Plus that's a little thick. That's actually falls in the line of slightly thick liquid. And then this mildly thick here, if anybody's ever heard of the thick liquids, they call them in the past nectar, honey, and pudding thick. Nectar, honey, and pudding were not good words to translate around the world, and they don't mean a whole lot, but mildly thick, moderately thick, and extremely thick are just nicely descriptive, and we can understand that extremely thick liquid is much thicker than a mildly thick or a slightly thick. So the words are very easy to understand. With your food side, there's liquidized, like just people who need things really liquidy, like soups and everything. And then there's pureed food, like your typical mashed potatoes, applesauce, that kind of consistency. And then minced and moist, when the food is really chopped fine and kind of moist and cohesive. This is soft and bite size, and it's making sure that the food is cut into small enough bites so that it helps to avoid a choking risk of big bites. And it's truly soft. We'll talk about that in a minute, where you can actually press a fork into it and it mashes. So we'll talk about that. And then the regular diets, has just one little tweak to easy to chew. And I'll mention that one in a minute as well. So ITSY's goal was to have safety through common terminology, those terms, for all ages, all care settings, and in all cultures. So, within the next few years, all hospitals, all nursing facilities, all home health care settings, and everywhere, outpatient settings, should all have this ITSY terminology to make sure that we're all talking the same language when you go from the hospital to a facility to back home. Everybody's speaking the same language, which would be the key. So food testing, um, ITSY comes along with just wonderful testing methods that really help us try and figure out what is soft, what is not soft, and it helps us categorize foods into things that are helpful to do, like keeping your food soft, making sure it's cohesive, not all crumbly and falling apart, making sure that it's slippery to slide down, making sure that you have nice small bite sizes, and small bite sizes with pieces of less than a half an inch are helpful to prevent choking. On this don't side is, kind of sometimes you have to avoid hard and tough or rubbery foods. You have to avoid crumbly foods, like even rice and corn and peas can be crumbly textures that just roll over the back of the tongue and can get down the wrong way. We also want to avoid sticky, gummy, slimy foods where like bread can kind of get gummy like that, and avoiding really large pieces or eating too fast if you're having any choking risk. So this example of this, was I was just alluding to there, is that bread is not necessarily easy to chew and soft and easy to swallow. ITSY considers bread to be only within the regular food texture, not on soft or minced or anything like that. It is a regular food item. I did want to just pause to show a little bit of why bread can be so tricky. And this is the fiber optic endoscopic evaluation of swallowing. I'm going to just grab that pause button there. Um, you can see here, see if I can get it to pause. Oh, trying to pause it on a spot to show you. What you're seeing here is the back of the tongue. There we go. So you're seeing here the back of the tongue here. This is when somebody is being scoped and it's just hanging down the back of their throat there. This is the back of the tongue. This is the back wall of the throat. The top of the picture is the back wall of the throat. This person was just obviously eating bread way too fast. And it just shows how bread is just kind of, gets glommed up or balled up here and can start dangerously falling towards the airway. If I pause that there, the airway is just right down below here. Every once in a while, we get a peak down there at kind of a triangle shape of where the vocal cords are. And so there you can see it's stuck, and then she has a big cough, and they're having to take the scope out to to suction her in a moment. So that's when the camera ended, yank the scope out and deal with. She did just fine in coughing that out, but that big ball of food is stuck right at the bottom, right over top where the airway is. So eating multiple bites of bread really fast is just not never a good idea for anybody. I'll go to the next one. This is an image and a YouTube link. I'm not going to play this whole thing here, but this YouTube link here is, if you search ITSY and minced and moist sandwich, it shows you how to modify bread to actually make a very nice minced and moist sandwich. The beginning of the video starts out with this image on the X-ray as well, of showing how bread can just kind of accumulate into a ball and fall down into the top of the airway there. So again, bread can be risky, and this ITSY has a nice recipe option. And there we go. And so with ITSY, there's nice food testing. So if anybody has any food in front of them, you can kind of do some of these things. This one's real easy, where if you have some pudding or applesauce or any kind of a pureed food, you can check how sticky is this. If you imagine your pureed mashed potatoes, and if it's been sitting out too long and it gets all cold and sticky, if you stick a spoon in it and you just try and tilt the spoon, it should just kind of slide off and not leave too much left over on the spoon. But if it's sticky, it'll leave a lot behind, and that's just not a good idea. I have got some pictures here. So when something is served nice and smooth, and moist and warm, so served warm, the food I had here passed this test well. So you scoop it up, you just tilt your spoon over, and does it just slide all off? This one did not pass. So when the pureed peas here got really cold and sat out for a while, when you scoop it up and try and flick it off the spoon, it all stuck to the spoon. So especially when you have things that are pureed, like mashed potatoes, pureed vegetables, pureed meats, you don't want them to be served cold. They get sticky. And then you can do things like steaming them, adding oil, adding sauce, making sure that your pureed foods are nice and smooth and moist. Then ITSY also notified us about the particle size. Um, our airway is about the same size as our thumbnail. So if you all look at your thumbnail and kind of just seeing how big that is, your adult thumbnail is about the same width as your trachea. So so if you have a piece of food that's a lot bigger than that and you have a choking risk, that could put you at risk for getting your airway blocked off. So it's also about the width of a dinner fork. So as you're cutting things up, cutting things up to the size of your thumbnail or to the size of across the width of a dinner fork is a good idea. These are the average adult airways: 21.5 millimeter for male, 17 millimeter for female. So that is quite smaller than you'd think, and so doing this soft and then small bite-sized pieces are going to be a lot easier and can prevent some choking or actual asphyxiation risk. Another test that itsy put out was the fork pressure test. So you can see my thumb in this picture here. You press on the fork until the thumbnail blanches white like that. It shows a good amount of pressure that you're putting into the food. And you want the food to be moist and kind of smash against the fork and actually deform and change shape when you press it like that. Foods that are regular, like bread or tough meats, you can imagine those are not going to squash with a fork. So they found that pressing things with a fork like that until your thumbnail blanches white was about 17 kilopascals. If anybody wants to get nerd out, as my son would say, in kilopascals in pressure. So our tongue uses about 17 to 20 kilopascals to push food, and they found that this fork pressure test could simulate how well our tongue may be able to push down food. So so we, to have something soft, we want it to actually be tongue mashable. So so doing this fork pressure test on food, it can be really helpful. So you see here they're doing a fork pressure test on this piece of bread. So again, the fork can be applied to the food sample. Observe what the food is doing when you're pressing on it, and does it squash or deform? Of course, bread doesn't. Bread doesn't squash well. And so again, you're pressing, the amount of pressure that we apply is until your thumbnail blanches white. And then here's another fail here. This was like a soft brownie, but it was really sticky. So also if you're pressing into something and then it just sticks to the fork and it's just super sticky, it would also not be a good idea. So you could make this brownie, easier to swallow, add some whipped cream, some chocolate sauce, and all that kind of stuff, and just make it a nicer, softer texture. And here's again a nice pass of a fork pressure test. This is like a chickpea vegetable stew here. You're pressing into it, it easily deforms, it stays moist and cohesive. So another one, fork separation test. This is good for that easy to chew. So if you're pretty much eating regular foods, but you just want to have foods that are just a little bit easier to chew, maybe your teeth are not so great for chewing, or you just do better with foods that are just a little bit soft and easy to chew. This is a good test for that, where you can imagine if you had lasagna or a nice piece of fish like this, you just go with the side of the fork. Can I just easily separate it? So fork separation test. Can I easily separate it with the side of the fork? That then can show you, well, I can then probably easily bite into the food. So if it breaks easily with the side of the fork or spoon, it's going to be easier for you to bite into it and to chew it easily. And then we get into the whole world of thickening liquids. I'm just going to play this video from YouTube here. Itsy gave us this concept of a flow test. So it's a way at home to be able to verify, are my liquids actually thickened to what my therapist told me to thicken to. So maybe you were prescribed on a mildly thick liquid, or what we used to call nectar thick liquid. Then you would just take that liquid, put it into a funnel, and for 10 seconds, you let the liquid drop out of the funnel, and then you cover it back up. Itsy has made fancy funnels here, but you can also, from your healthcare facility, just get a 10 ml syringe. And I'm just going to play that here from YouTube. That's the link up there that's playing. And this just gives the flow test instructions, and you can find this on YouTube, telling you to use a 10 ml syringe and a stopwatch. Um, you just use the bottom part of the syringe. So you just take off that plunger. You don't need the plunger. You just want that 10 ml line there. And you can see how they're going to just add liquids to the top. You pour them in there. They're showing you how to make a seal on the bottom. So if you use another syringe to put it in, or I just pour in the liquid on the top, get it up to the 10 milliliter line, and you get your stopwatch handy, and you just count out those 10 seconds. And as the 10 seconds go by, it's kind of like, okay, 7, 8, 9, 10, and put the finger back on the bottom. And this one shows that there's only 2 milliliters left in the syringe. So this one shows that you've created a slightly thick liquid. If you wanted a mildly thick liquid, it would be 4 to 8 milliliters. And there's this flow test information is in your handout. And we can always go over that more if anybody needs it. I have another YouTube link here. We're not going to watch the whole thing again, but again, it shows you the new itsy funnel and how it actually helps you classify slightly thick, mildly thick, moderately thick. And again, it's how much liquid goes through in 10 seconds. It's based on old thickening techniques and was designed by somebody in England. So it's just a nice do it at home level of, let's see if this is really the right thickness. So if you're thickening liquids at home with thickener powder, or you're making a frap in the blender, you can always just double check how thick the liquid is. And so flow test cards I have in your handout there. And so again, a thin liquid just goes right through the syringe, of course. Slightly thick is the level 1. Mildly thick level 2, moderately thick is level 3 there. If you have an extremely thick liquid, you can just use that spoon tilt test, and it doesn't go through the syringe at all. Here's information on those funnels. You can ask your healthcare provider for any 10 ml syringe like these. And then there are itsy funnels that maybe you can even get from your therapist, because itsy sells them in big bulk amounts. You don't need 100 of them. And then also simplythick.com's their website sells in sets of 10, which again is too many for your needs. So find these things from your healthcare providers. And if you need more info on itsy, there's an app that you can put on your phone. Just search itsy in the app store on any Android or Mac or iPhone. So other treatments, we'll just kind of cruise through this section a little bit. Sorry, going fast, but I do want to leave some time for questions here, and we'll just kind of go through this a little bit. And the compensatory strategies, this is one of those pillars as well, where these are things that we can test on video to help increase the safety, prevent aspiration, or increase the efficiency, how well the food goes through. One of the big things is to reduce distractions. Like we had mentioned, don't multitask. Like if you are having some trouble swallowing, just try and do your meal and not do all the extra checking your email and everything like that we do. Um, Sometimes taking a liquid and tucking your chin helps. Sometimes it doesn't, though. So it's really important to double check that on an X-ray. Often smaller bites and sips help. Taking a bite of food, washing it with a sip of liquid, that, alternating liquids and solids can sometimes help. Doing an effortful or a hard swallow, push with your tongue, squeeze with your throat muscles. Sometimes you have to avoid certain foods, add sauce, do single sips by cup rather than chugging by straw. And then for pills, we had mentioned sometimes that pills can be hard to swallow when you're taking a pill plus a liquid. So putting them in applesauce, or there's a company called Phasix that makes a pill swallowing gel, and you can put the pill in that gel and swallow it that way. And that can be a handy trick. So effortful swallow, this is swallowing hard. You can see where you really kind of think about the tongue. So pressing the tongue into the roof of your mouth as you swallow hard. And you feel that squeeze with the tongue push and the throat muscles squeeze. You can do this on x-ray with your therapist and learn about how it's helpful. There's also you can, yeah, so I have here, ask to see your swallow on x-ray and with endoscopy, and you can learn to manipulate it, like see how it looks when you swallow hard, or sometimes people just sort of develop ways that protects their airway, and you can then see that on x-ray. There's also, you may have heard of this before, LSVT, Lee Silverman voice treatment. So this is really trying to ramp up your voice to overcome this concept of hypokinesia, or this reduced movement that can happen with Parkinson's. It also causes reduced movement in the breathing and in the voice. So when we think loud, we're trying to recalibrate our system to really try and always think loud, always get that voice out better, and there's resources there. There's also this other Parkinson's Voice Project. It's quite a similar program. People have had a lot of success with these guys as well, this Speak Out program, or Speak with Intent. So you're really using a different motor system that's not impaired, to kind of overcome or recalibrate the system that is impaired. And there's just a little sort of handout about the process of the Speak Out therapy program and the links as well. So research has supported the use of this intensive voice training to actually then cross over and help with swallowing. So just a little bit of info. If you're doing this kind of voice practice 4 times a week, even just for a month, research has found less residue in the throat, better opening of the upper esophagus, better voice, of course, but also getting improved elevation of that larynx, when I showed you in the beginning, and even some of the research carrying over to better quality of life. This research found less of that rocking tongue motion and a better clearance of food through the mouth. So it's all really promising. There's also this emst, and I have one right here. They make these nice mouth pieces too, to really help seal your mouth around it like that. And so when you're blowing through this, you'll hear kind of a whoosh out the side, and then you can calibrate it for how much pressure you have to blow to get the whoosh of air. And research has found good improvements with somebody's ability to cough and to help clear aspiration. And overall, we really want to encourage cough. A lot of times people are worried when they hear somebody cough, and it's kind of good to be aware that somebody's coughing, but also to really encourage that cough. That's our airway protection to eject stuff. And so again, research has supported the use of working on things like the emst, or even just working on cough as well. It's showing good signs of reducing stuff getting down the wrong way, the penetration into the airway, or aspiration all the way down to the trachea. There was a randomized control trial that showed not only less stuff getting down the wrong way, but also better movement of that hyoid, better opening of the upper esophageal sphincter, and better clearance and less residue. And Michelle Troche, she's in New York City. She's just done so much research on cough and on this emst and everything. And their study here showed that even after 3 months of no exercise, there was still good gains. There was no loss of gains. So that's really good. And so medications, there's drooling and the medical word for drooling there. And so sometimes there's medications that you can help to gently dry up secretions, but you also have to be a little bit careful. I have the details here where you can always go over this information with your doctor as you guys decide on medications, because some different medications to dry up secretions can also cause a little bit of cognitive effect. It's called anticholinergic side effects, which sometimes can cause a little confusion. So as you try and fix one thing, it might cause a little side effects with something else like that. So it's something to be aware of. On the other side of things, sometimes people with Parkinson's have dry mouth. Sometimes Cinemet, as it gets up in dose, can have some medication side effects of dry mouth. And then you can use some saliva sprays like the Biotine or this Lubricity. They both come with these little handy sprays where you just spray the material in the mouth, and it's kind of a slightly thick liquid that just coats your mouth and feels nice and moisturizing all over the mouth. And it's something where you just sort of like swish it around and swallow it, and it just literally, I always say, coats the pipes. It's like plumbing. Okay, so regardless of whether you have too much or too little saliva, again, it's just still really important to keep your mouth clean, brush, floss, use mouthwash, and all that is great for aspiration pneumonia prevention. Sometimes medications can actually help the swallowing as well. You guys were talking about your Sinemet medications and making sure that you really keep it on the schedule that you need. So Sinemet has been found to improve the safety and efficiency of the swallowing. We always want to make sure that people are taking it, about 30 minutes before a meal on an empty stomach for the best absorption. And I think you guys were just talking about when I came on that how the Sinemet can compete with food proteins in the stomach, and as you start needing more and more Sinemet, maybe it's hard to to keep it on the empty stomach a half hour before meals. But we really have found, in old research as well as even in newer research, that the swallow can be better when you're feeling that on effect of Sinemet versus when somebody's off Sinemet or having that off effect. Sometimes people can feel very frozen and very, just trouble with their whole body movement, but that also can go into having more trouble with the swallowing. So when we see people in the clinic, we want to know, when was your last dose, and are you eating off medications sometimes, or are you always trying to eat when you're feeling on medication? And I do have this video example here. I'm going to pause though before we watch this and see how much time we have maybe at the very end to take a look at this. So I'm just going to cruise through some nice video examples. And what this was is that somebody just did so much better when he was on Sinemet versus off. So I'm going to pause for questions. I just want to let you know, with the PDF, I do have lots of references that you can always refer to these when you're talking with your therapist and with your medical team. So I'm going to see if I can stop share. And where is the stop? There it is. Stop sharing. And if we're good coming back on here, let's see.
So that
Good,
was wonderful. Thank you so much. I mean, we've had,
Sure.
different people speak, guest speak for various topics. And here, let me stop the recording too.
Yeah, go ahead and stop the recording. Yeah.
Let's see here. There we go. Okay.